So the management of the uncommon EGFR mutations in NSLC. So next slide. So usually this is the spectrum of mutations in the NSCLC. We all know adenocarcinoma consists of 55% of the lung cancers. No need to introduce that. And also EGFR sensitivity mutation in India, in South India, it's almost like going up to non-smokers going up to 40 to 50%, I would say. So with this, not just these EGFR mutations are all common. Exon 19 or exon 21, like exon 20 different mutations are there, and also uncommon mutations of exon 19 as well as 21 is also coming up. So today our discussion is regarding uncommon EGFR mutations. So once the patient walked into our place, like how we are going forward. If you see the spectrum here, EGFR, other mutations, MET mutation, HER2 mutation, ROS, BRAF, RET, all these things are there which are considered less than 5%. I would request to Dr. Tarachand sir. So how many patients of yours had, other than EGFR, non-EGFR mutations you have seen? ALK EGFR chhod ke, like how many people you have seen who are having other mutations, even KRAS also?
Yeah, Kripa, if we talk about that, the KRAS, only one patient till now. And ROS1 patients, only 2 patients till now. MAT amplification, only 2 patients till now in last 6 years. 2 or 3, I think. And RET patient, I did not see in lung, just in GBM, I saw that. And other uncommon EGFR mutations, only one exon 20 insertion and one is uncommon EGFR.
Okay,
blah, blah,
okay,
blah.
okay. Okay, so what about RAS, BRAF, RET2 and everything, sir?
No, unfortunately, I have not seen any BRAF positive patient in lung or even in melanoma.
Okay, you haven't seen. Divesh, sir, I would request you to share your experience regarding uncommon, non-EGFR mutations, I would say. So, EGFR, ALK, like a BINA, like whatever mutations you have seen, just please share the experience with us. What percentage and what mutations you often see other than EGFR, ALK?
Yeah, so definitely I have seen the HER2, 1 patient, BRAF 2 patient, and I think KRAS is also 3 patient I have seen, other than the EGFR.
Okay.
Rest I have not seen.
Okay, you have not seen. Okay. Sir, other sir, names are like, what about like?
Yeah.
Deepak sir, Deepak Shukla sir.
So
Sir, can you share your experience?
Yeah, so it is similar to what Dr. Tara, Dr. Devesh mentioned, but again, recently, means around 6 months back, I saw a patient with EGFR and HER2 mutation, both occurring together. I've seen, I think, 2-3 patients with BRAF mutation, MET mutation, both amplification also, and exon 14 skipping mutation. I have not seen NTRK, KRAS, G12C. Again, particularly, I don't remember the percentage of G12C, but as such, KRAS mutation is very common. G12C, because we do not have the drug available with us. So, but again, as you have rightly mentioned, majority of the patients who are non-smoker or male or female, majority, what we see is EGFR mutation. Even I'll say ALK is also not common. It is uncommon, as according to what I see in my practice.
Okay, understood. So whatever.
Sorry. Dr. Rohit is also joined.
Okay, Dr. Rohit sir.
Yeah, Dr. Kripa, I agree with the other panelists. I had also seen KRAS mutation 2 or 3, 2 BRAF mutations, and yet not seen any MET amplification.
So KRAS, when you have seen it like concomitant with EGFR, you have seen, or KRAS alone you have seen, sir?
Alone.
So are you acting in the first line, or are you reserving your sotorasib or something else like in the second line?
Actually, at present in the second line. At present in the initially going for chemotherapy.
Great. So coexistent mutations, you are not going, it's just prognostic. That's it, right? You are not going to use it in second line also, just prognostic.
Yeah.
Great. Next slide. So it's a typical case like what I'm mentioning, this case from Dignity 1. So 63 years old female, non-smoker, no uncontrolled comorbidities, ever with the cough, shortness of breath, and there is a multiple lung mets, pleural effusion got noted and found to have a pulmonary adenocarcinoma. Next slide. So this one, I want to understand what kind of test we are doing and in Jaipur. So DNA-based broad panel NGS test, RNA-based broad panel test, or any other. So what panels we are using? I just want to understand across the country. Dr. Tarachand Gupta, what panel you're, sir? What panel you're using, sir?
DNA-based broad panel NGS we are using.
You're not using RNA-based one.
Yeah, I think RNA DNA मुझे याद नहीं है, but मेरे ख्याल से DNA I don't know.
Divesh sir, what about you, sir?
I think it's still DNA-based broad panel NG sequencing.
So RNA you are not at all including in along with the DNA.
Yeah, we are including the RNA-based. I think 2 or 3 mutations we are including. So I think DNA RNA mixed base broad-based panel NG sequencing. Yes.
Yeah, so we are doing at Manipal. We are doing it with Dalpet. So initially, I think it was Novartis that came up with the coupon with this both DNA and RNA NGS of 12 gene. So we are doing that 12 gene panel, which is both DNA and RNA based NGS, and in addition, we do PDL1 also. Only one question I wanted to ask: where means suppose in a patient, if you get a diagnosis of non-small cell lung cancer, where do you straight away go with the molecular test, or you do some basic IHC and then go for NGS testing?
Yeah, sir. It was like previously when we were students, we used to do the ALK IHC and hot spot mutations. We used to do it. Right now, with the availability of a lot of coupons from various pharma companies, we are like straight away sending for the 12 broad gene panel, 16 broad gene panel plus PD1. Accordingly, we just selecting. That's it. We are not just doing one basic IHC or something. But usually the TAT of IHC ALK is like just 2 to 3 days. When patient is a non-smoker, when patient has a brain mets in the baseline, I do really incline to start to do the ALK IHC in the very beginning, so that in 2 days I get the report, I can start the treatment also, I can avoid radiation also. Apart from usually I'm waiting for some time, unless brain mets, nothing alarming, I'll just wait for NGS report. That's it.
So just means my experience is, as we previously discussed, that majority of our patients are having out of this profile of patients who are non-smoker, female or male. So majority of these are EGFR mutation. So one of the challenges means I have a patient who came out to be ROS fusion positive in NGS, but she had brain met. She expired 1 to 2 days prior to when the report came. So that is a challenge in my practice. Particularly, I remember around 3-4 patients who are having leptomeningeal mets. I personally send ddPCR from blood for EGFR. The report comes in 2 days. And my preference is to start osimertinib once I get the report. So this has helped me, means because the patients are very apprehensive when they are initially diagnosed. It is a challenge for a patient when we are saying that patient is having brain mets. We are going to wait for 2 to 3 weeks, 2 weeks for the report to come. So this is one of the experience that I had with sending ddPCR. The reports come in 2 days. Around 3-4 of these patients went on to receive osimertinib.
So you send EGFR as well as ALK both?
Yeah, no.
Right.
What means, as I mentioned, that in my clinical practice and as such, we know that most common mutation is EGFR. Okay, so particularly if a patient presenting with leptomeningeal mets, I think as such, if we look into the overall incidence, EGFR would be the most common mutation which we are expecting. So I have sent ddPCR, and possibly ddPCR from blood has a good sensitivity. So means some of these patients turned out, means their report came out within 2 to 3 days. And one of the surprises was one of the patients, I sent ddPCR from blood. Her T790M mutation came positive. She was a female non-smoker, and the NGS that we sent from biopsy and later on from the blood also, that came to be negative for any mutation. Okay, we gave that patient because of her performance status osimertinib, and she was able to survive close to 18 months. Not 18 months, around 12 months. Means so this was a rare presentation, baseline T790M detected on ddPCR, and both the NGS from the tissue as well as liquid biopsy just we sent to confirm, because baseline T790M Though I retrospectively reviewed it, it can be there in around 1% of the patient. But this is one experience that I particularly find helpful in clinical practice.
Okay, great. And this is a really value addition to our knowledge, sir. Thank you so much. And also, Rohit sir, anything else you practice, sir? Like, what's your practice regarding the lung mutation testing?
So yeah, I also go ahead with the combined DNA and RNA based NG sequencing in all the patients.
Okay. You're using coupons or you're having in-house panel, sir?
Yes, no, I am using coupon, not in-house panel, but using coupon, and coupons are associated with core diagnostic and med genome and other. So I am sending both of these DNA and RNA based NG sequencing.
Right. Okay. Divesh sir, what about you, sir? You told like you'll use both DNA and RNA.
So I think we are using the coupon based. So the panel based, the coupon from the core as well as the med genome and the various other labs. So I think they are doing both DNA and RNA based broad panel NGS.
Very well taken. Next slide. So the EGFR epidemiology, just want to understand. So this is a broad spectrum of EGFR epidemiology. So what kind of mutations we usually see? The rare kind of mutations, like how often we have seen in our clinical scenario. Dr. Rohit, like how often you see the rare EGFR mutation? Or you're like only just you're seeing most of them, so 19, 21 and all?
Most common are 19 and 1, but still definitely I will say 4 to 5% of these EGFR mutations comes out to be rare mutations.
Divesh sir,
Like
rare mutations you do see.
I observed only 1 to 2%. 1 to 2%.
1 to 2%. T790, how often you see, sir?
I think I have seen recently within 2 months 2 patients I have seen. So I think the proportion is still as Dr. Deepak sir said, only 1%. So I think I have seen 2 patients in last 2 months.
So EGFR predominantly located in exon 18 to 21. The specific EGFR mutation identified is important. Sensitive mutations, primary resistance mutations, and de novo and acquired resistant mutations. All of us know as the time passes also there can be resistance to EGFR and the exon change also can happen. So even the patient was like initially exon 19, we know that it may turn up into exon 20 mutation as well. If the patient is osimertinib, like we really can't do any change. But if the patient is not on osimertinib, then there is a fair chance for the patient to convert from first generation to second generation. Or some EGFR mutations are sensitive to the first generation, or some dacomitinib based one. So that's a very rare scenario. Let's go through some questions like in this scenario. Next slide. So it's an overall view is this one. So atypical uncommon EGFR mutations, including 6719X and L861Q, S7681. Some are sensitive to traditional EGFR inhibitors, more studies needed. But exon 20 insertions are resistant to traditional EGFR inhibitors, new drugs got approved. So this exon 20 insertions, all of us know amivantamab is a good drug. We all have some clinical trial experience in the major centers. So anyone has an exon 20 insertion experience, and what is the role of amivantamab? Like how good response you have seen? Dr. Divesh sir, can you please throw light on this?
I think I have seen just one or two cases, but I have not treated this with this amivantamab. So I have no clinical experience, but I have seen 2 cases.
Right. 2 cases you have seen, but you haven't treated with amivantamab. You just treated with pemcarbo.
Yes. No,
Rohit
no.
sir, no. What you use, sir, for that exon 20 insertion?
So I think I have not treated because the patient is not fit for further treatment.
Okay.
And patient are not willing for the chemo as well as the other agents.
Great. Rohit sir, so have you seen exon 20 insertions in your practice? If yes, is there any possibility
I
or
had
any
seen around
experience?
I had seen on around 2 to 3 and treated with pemcarbo and afatinib.
So afatinib used?
Yeah, used in one patient. And
did they respond, sir?
Yeah, she responded.
Okay, great. So, Dr. Tarachand, sir,
I have already told you that I have seen only one patient exon 20 insertion one or two other rare mutations, EGFR only till now.
That
in
one
last
patient,
6
what you
years.
treated, sir? How you treated that single patient of exon 20 insertion? How you treated? I want to
He
understand that.
he was planned for the second line amivantamab, but before that he left me.
He left you or he left the world?
Yeah, no, he left. He did not. I don't know what happened to him, but he did not come to me again after the progression on first line.
Okay, so you used Pemcarbo. So, but you didn't. No one used amivantamab now. Sir, Rohit sir used
No,
afatinib.
not used amivantamab yet, but yeah, use
Afatinib, I
afatinib.
meant saying. Yeah.
Yeah, yeah.
So
Divesh sir?
I have also not used. I have a patient, means she was around 1 liter of oxygen. Her report came. Ultimately, we called her for follow-up. She had expired by that time. So means
Okay.
again, one of the challenges with doing NGS is means some of the time we do not want to start the treatment. Some of these patients are not fit for chemotherapy. So we wait for NGS, possibly waiting for some targeted mutation that can come. But we definitely lose few patients during this waiting period.
Understood. Great. Any other inputs you want to add on this one regarding exon 20 insertion, which constitutes 12.8% out of all the lot of uncommon EGFR mutations, or whole EGFR mutations?
So one
The
of the
uncommon.
options, yeah, for one of the options is osimertinib 160 milligram. That is one of the options. Suppose a patient see both drugs, even osimertinib giving at 160 milligram is very costly. Amivantamab is also very costly. We previously had this mobocertinib, and those have been withdrawn. So possibly OC 160 and amivantamab are the two most active drugs that we have.
Great. Next slide. So the somatic mutation status and solid. So liquid and solid, I just want to understand how common you send liquid biopsy also along with the solid biopsy. So what's your opinion regarding liquid biopsy, sending in a lung cancer patient? There is a data coming up for concurrent sending of the solid NGS as well as liquid NGS. Dr. Deepak sir, please tell me.
Yeah, so again, as previously mentioned, ideally at baseline from the block, we do both DNA and RNA NGS. In a particular profile of patient like this patient who was a female non-smoker and any male non-smoker in a given background, we always keep on searching for a mutation. So even though our biopsy maybe means NGS from the biopsy is negative, possibly one of the circumstances where I may counsel for doing a liquid biopsy, even if the NGS from the tissue is negative, possibly this profile of patient where we see these type of mutation, possibly one of the circumstances is to do at that time, and also possibly after first line treatment with osimertinib. So we know T790M, but we know other MET exon 14 skipping mutation, and some of the time doing a repeat biopsy. Most of the time patient do not agree. Possibly in those in that setting, I'll go ahead with liquid biopsy.
Okay. At that setting, you'll go for liquid biopsy. Okay. Sir, Rohit sir, did you see, do you really send liquid biopsy also along with the solid, or you want to send only solid? Or if solid is like negative, you want to send liquid? Just you want to continue the same pattern what Dr. Deepak Shukla has said, or you want to have any other thing to add on?
Please unmute Dr. Rohit.
I'll prefer to send both solid as well as liquid NGS at the same time, so that anything is missed in the solid NGS then can be picked out in the liquid NGS, and the time interval will be same. But at present, if I am having a block, I am sending most of the NGS on the block itself.
Understood. Sir Tarachand sir, how you want to practice like both?
Usually we are sending NGS on biopsy block only, and sometimes we tried that in a 1 or 2 patient for liquid biopsy, but some labs told us that they can do only EGFR on liquid biopsy, not other mutations. So this becomes very difficult. So we usually send only on the biopsy block. And
Non-smoker
I think,
patient, non-smoker patient biopsy NGS is negative. Will you send liquid biopsy or you just want to start chemotherapy for her? Plus or minus immuno.
yeah, I will start chemotherapy.
You will not send again liquid to reconfirm it's a negative.
No, I don't send you.
No, it is not like we can, means what I was trying to convey is we, if a biopsy NGS is negative, we can start with chemotherapy. And meanwhile, just on at the back of the mind, we can always discuss that, means possibly there is whatever percentage, let's say 5-10%, there is definite chances we can pick something on the liquid biopsy. One more point, sometimes patients do come to us when they have done EGFR by PCR and IHC for ELK, means previously what was practiced doing single gene testing. So in my personal experience, I've seen patients who have done these patients, once we do NGS, some of them do have EGFR mutation that was missed on PCR.
Understood. So there's a compound mutation report is here. It's a mutation detected in the exon 20 as well as 21. So how you want to take this one? Here it is, it's like this is not T790 mutations. So how you want to treat this patient? Next slide. So would you be interested in PD-L1 status of a patient who is like positive for EGFR mutation? She's having compound mutation like exon 20 as well as exon 21 mutation is noted. It is non T790 mutation. So patient is sufferable. All of us we are really inclined to do the osimertinib alone. Like if it's not so, we'd go for the first generation TKI. So in EGFR mutation patients, will you do PD-L1? Divesh sir?
I think we are sending the combo panel along with all mutation panel. We are sending the PD-L1 status. So I think there is no need to separate, but we are sending the both samples, PD-L1 as well as the targeting all these mutations.
So you want to reserve the second line, like the regimen is there, like where IM power trial is there. So where we want to add atezolizumab, all this further stuff you're doing, or you're just doing like as a combo you're doing.
We are doing, but we can reserve in the second line also. We can reserve.
Right. And also I showed the compound mutation of exon 20, exon 21. So have you come across any such case with compound mutation, and what's your experience regarding the outcome? Usually when there is a compound mutation, it was known that patient will not do as good as the patient who are having single mutation. And though we use osimertinib also, there is a high chance of likely to have a less PFS. So did you have any such case which has a less PFS? The response is not what you expect for a just regular one.
No, I have not observed these type of cases, but I have observed even if EGFR single positive or PD-L1, I have not encountered any such cases.
Okay. Rohit sir?
Yeah, so as Devesh sir said, initially only we send all the NGS as well as the PD-L1 testing. But if the patient is having a rare EGFR mutation like insertion 20, which is not so much responsive to TKI, then definitely in those patients, I like to explore the option of PD-L1 also and option of chemotherapy or addition of immunotherapy with chemotherapy. So if I hadn't done PD-L1 on the baseline, so in the rare mutation patients, I will definitely go to look for PD-L1 status of that patient.
Okay, great. Next slide. So for this patient, what will we plan? So there are two mutations are there, exon 20 as well as exon 21. This is a compound mutation. What is your choice? Tarachand sir, only osimertinib, or you want to add something else like TK plus bevacizumab, like Erlo plus ramucirumab?
If this is exon 20 and 21 both are there, then we can give osimertinib, or we can go with the FLAURA2 like pembro carbo plus osimertinib in this case.
Pem-carbo osimertinib, you want to give patient is fit enough.
Yeah. Otherwise, because this is the this patient is going to worse later on and will relapse very soon. So it will be better, in my opinion, to take care with the chemotherapy along with the osimertinib. And osimertinib will be the best choice for the both mutations.
Yeah, I do agree with you, sir. The FLAURA2 is a really blockbuster, I would say, because previously all of us used to have experience on Pem-carbo plus gefitinib, but osimertinib with chemo
Yeah,
Yeah,
but
in
Kripa,
in page
if this patient is PDL1 is also positive,
you
and
want to
you
add
can
what? You
say,
want to add immunotherapy also?
yeah, no, I am just asking if it is this is PDL1 more than 50%,
No,
then
the
what is
driver
the
mutation positive, yeah, driver mutation positive, even though it's a 50% more is there, the response will not be really good with the addition of immunotherapy.
Yeah, even in second line, this is not better. So that's why I
Yeah,
prefer immunotherapy in third line. In these cases, after the TKIs, and continue the TKI with chemotherapy in second line, and then go to the with the immunotherapy in third line, because there is strong data that immunotherapy is going to do worse in these cases in second line.
okay. Rohit sir?
Yeah, definitely. I'll also like to go with osimertinib and chemotherapy in this patient. And if the patient is not affording, or if you see my second choice, so my second choice will be afatinib, because it acts in the these rare mutation insertion 20 as well as on the 21. So these are my
Okay,
options.
So actually,
okay.
I'll like to add something. So for FLORA2, we do not have any data for rare mutation. So only patients with exon 90 and L858R patients.
Yes, yes.
Okay,
Yes,
so the
but
best data. Yeah,
still,
yeah.
FLORA2 has shown that there is a compared to osimertinib, like combination of chemotherapy, just like Tata trial, there is a
Mm.
benefit is there. For
Yeah,
compound mutations, all of us know that osimertinib alone, Artic alone may not be really great drug.
yeah.
So if ever we want to add on the benefit of chemotherapy plus both worlds, best of both worlds, I think that's a better combination. I would definitely, I will certainly prefer that combination.
But we do not have data for that. Okay, so
Yeah,
what
data nahi hai,
we have,
but it's a very practical
yeah,
to
but
implement that. Yeah.
what data we have is for best data is for afatinib and possibly a Korean data of 30 odd patients for osimertinib. And again, these mutations are rare. Whenever we see, we should go back. Even these three type 2 mutations that are there, they have different sensitivity towards afatinib and osimertinib. The particular mutation what this patient is having is possibly more sensitive to afatinib as compared to osimertinib. And for EGFR mutation patients, they may have a very high PDL1. So again, that is not the driver as already mentioned. So particularly for me, I'll go with afatinib in this case. Definitely option of pemetrexed, gefitinib or pemetrexed, osimertinib are good option. But again, we do not have data in this rare mutation. So we do not know how they'll will they do better as compared to afatinib. I think the comparator arm in that case would be afatinib rather than gefitinib, or let's say osimertinib. For this
Okay, sure.
mutation with EGFR with this rare mutation.
Right. So Divesh sir, for the
Dr.
compound
Kripal,
mutation, you
sorry,
want to go for, yeah, sir.
last
Someone is
2
talking.
minutes. Yeah, okay.
Yeah. So we'll close up with your opinion, sir. For the compound mutations, you want to go for FLORA2 regimen, or just like Dr. Deepak told, because data is not there in that, you want to go with the single agent osimertinib or afatinib like that.
I think there is the two opinion, chemo plus osi versus afatinib.
I will vote for chemo plus osimertinib, because compared to afatinib, osimertinib is a better drug for sure. And also only some mutations have a affinity for the afatinib. So if ever I want to really add on because I know the compound mutations will not do as great as regular mutations with
We are
osimertinib.
actually
I'll certainly,
for this case, na, you have given a case for this particular mutation. We are discussing the answer. It is not general.
right.
Okay. This particular case, I think we don't have any data for rare mutation of with osimertinib with pemetrexed carboplatin. We are already discussing whether we should for exon 19, 21, should we go ahead in all patients with the combination of FLORA2. This is a totally different patient. Okay, this is a rare mutation with in EGFR. So in this particular setting, do you have any data? See, the means it is exciting, it could work. That is a different issue, but we do not have data for.
I'll certainly, though I know osimertinib compared to single agent combination is better, and getting pooling up of a large data for uncommon mutations is really rare because it's a few percentage, I would say. So because I have a data regarding exon 19 and exon 21, definitely I'll replicate that in the uncommon mutation, because certainly I know single agent osimertinib is really not going to be better fit. So that's why I will add, because I'll replicate the same, because doing the pooled analysis in such scenarios like not at all going to be possible in near future also. So that's why even exon 20 insertion is also like at least better than this compound mutation, having compound mutation. Indomircan, when we analyzed only in the large data, we found only 3 cases having a compound mutation, only 3 cases in the thousands of patients. So if that large data is having 3 patients across the India, also if we collect, it's really hard to get patients to perform a trial. It has to be pan global trial, I would say. But replicating the data from exon 19 and exon 21, definitely, certainly, because osimertinib is going to work in all the 3. So why not we club the chemo and this one when we know that the response will not be as good as a single mutation. That's what my take. Though the data is not there, certainly I'll practice as Dr. Tarachand suggested, Rohit suggested, I also do the same.
Ma'am.
Who is that?
Yes. Ma'am, what your thought on the toxicity of the FLORA2? Especially
FLORA2, right now, the oldest patient who is taking FLORA2. Right, I'll add on that. Yes. So right now, the oldest patient who is taking FLORA2 regimen with me is a 72 years old male patient. So he has no toxicities at all. And also the osimertinib what I'm using is not a, I think this is okay to talk in this panel. So I'm not really using the original molecule also. I'm using the Bangladesh molecule because it's not really affordable. So the response after 3 cycles, he got a near complete response. I'm happy with it. In whatever patients I'm using, the FLORA2 regimen, only 1 patient is on the Bangladesh, rest 6 are on the original one, AstraZeneca one. And all 6 got a very good partial response. This guy got a near complete response because this is not so great, actually, not so high. But because he's a really fit guy, I really tried. He's an army man. That's why I tried this one. So the response is good and toxicities are really not high. Just like Jeff studies there in TMH, it's almost really the same. It's not really high. It's really well tolerated in my practice. I would like to take a opinion from all the people who practice the FLORA2 trial. Is the toxicity really high? You found it, or you found it's like really manageable and it's okay to sort it out?
See, I will, in my practice, FLORA2 I'll use for patients who are young, having brain mets. Possibly the best data to be used is for these patients. Across spectrum, I'll change my practice to FLORA2. Again, it is means we do not have OS data. So particularly in a patient with
Data trial has shown recent update also there is a significant OS data is there. It's only gefitinib based one.
Yeah, but for TMH, for this OC with the pemetrexed carbo, I think presently in my practice, I'm choosing for these patients. Possibly down the line, obviously we do not have much options. So possibly down the line, as the data matures, I'll change my practice to all of them. But presently, I'm doing for patients who are having brain mets or possibly younger who can means. Down the line, even with pemetrexed, gefitinib, I have seen renal toxicity. Means I have 2-3 patients down the line whose creat start to worsen and I think all of us will be we have to withdraw pemetrexed and continue with gefitinib alone, even with TMH, the protocol that we use.
Tarachand sir and Rohit sir, who voted for FLORA2 and who saw the evidence of PEM plus GFGC with a very good outcome and less toxicity. What's your take on FLORA2 trial? What's your toxicity experience?
Yeah, toxicity is manageable. That's not so much toxicity with the combination of osimertinib and PEM carbo. And at present, 2 patients are going on and they are fine. Matlab, that there is no much toxicity with the PEM carbo and osimertinib.
Okay. Rohit sir, Tarachand sir?
Yeah, toxicity, I think osimertinib is a wonderful drug. I did not see patients who are having more than grade 1 diarrhea or grade 1 rash with the osimertinib like other TKIs. I have not seen the patient like that. So toxicity is manageable, and with the PAM carbo plus osimertinib, I have not used that. But I still if the patient is coming with PS3 and patient is treatment naive of lung cancer, patient can be fit by only single agent carboplatin. So I think within 7 to 15 days, patient become fit for the And third thing, in my opinion, that we cannot have the trial for each time, each mutation. If we know that the osimertinib, if osimertinib is PEM carbo plus osimertinib is better than osimertinib in the indication approved for the osimertinib, then I think where we are using osimertinib, we can use PEM carbo plus osimertinib as a FLORA2, as this can be extrapolation of the data only. So it is not possible that every time we will collect that rare mutations and common mutations including. So this is my opinion. And otherwise, I think rest are them. But still, I am not using with PEM carbo plus osimertinib because it is difficult to counsel the patient if he is having or she is having positive for the driver mutations. Please take the chemotherapy also.
Right. Wonderful. I think it's time to conclude this panel discussion. Otherwise, Divesh sir will, openly ask me to shut down the screen. So thank you so much for this opportunity, sir. I learned a lot with this brilliant panel discussion by a brilliant panelist. Thank you, sir. Thank you so much.
So